Thank you very much for that fantastic presentation. It's amazing to see how your group has just led the clinical development of this field, and thank you very much. Okay, we'll now move on to the scientific abstract portion of this session.
All right, let's thank both of our invited speakers one more time for those fantastic talks. Our first speaker in the scientific abstract section will be Ethan Johnson, presenting fully automated quantitative 4D flow MRI, a study in 387 adult and pediatric subjects.
Thank you. So good morning. What I'd like to share with you all today is our efforts toward automating the processing for quantitative 4D flow MRI. So you're all, I'm sure, quite familiar with 4D flow MRI. At a basic level, what it gives us is direct visualization of the blood flow. Here's an example of a relatively early study, a case report of a BAV patient. And we're seeing from the 4D flow how we have these very complex flow patterns through the aorta with the sort of nested helices. Here's another example with, for instance, the streamlines showing the acceleration of blood as it moves through the bend of a coarctation in the aorta. Where 4D flow MRI really becomes a powerful tool for science is when we pair it with quantitative analysis to characterize the hemodynamics. So for example, we could quantify peak velocity in different regions of the aorta. We could estimate the aortic wall stiffness using pulse wave velocity. And there are many more parameters that can be accessed through 4D flow MRI. For doing this processing, we have kind of a standard flow. We start with our magnitude and phase images. We apply some pre-processing corrections to convert the phase into a velocity vector field. We then would go into our images and pick out a region of interest, segment a vessel that we're interested in, and perhaps also delineate some subregions of that vessel. And then finally, we're ready to do our parameter analysis. So zooming in a little bit on some of the pre-processing step, this entails noise masking, background phase correction, and phase aliasing. First, we have to load the data. This can take some time. We have to set some thresholds manually. And then maybe we have to look for any phase wraps that need correction as well. So that's quite time consuming. In terms of segmenting the vessel, then we have our velocity data. We could perhaps generate a phase contrast MRA. That's a pretty good start, but we then have to load that into another program. We have to remove the regions that we're not interested in, make sure that we've included everything that we are interested in, and then finally delineating the subregions of the vessel that we're interested in. So overall, that's quite time consuming, but as I'm sure also many of you know, in recent years, we've had some good demonstration of the power of machine learning techniques for doing some of these types of tasks. So we have an opportunity here to convert some of the manual human input into an AI-driven process. The network architecture that we're working with is a UNet that's generally been shown to be quite successful for segmentation tasks. And if you look at the pre-processing steps, those can all be formulated as a segmentation problem. Obviously then segmenting the vessel and delineating regions, those are also segmentation problems. And so we can train UNet to do each of these tasks. We can then go back to our processing pipeline, and we can substitute each of our 5 trained UNets for what the human was formerly doing. We then take an additional step, which is that we encapsulate all of our processing modules into individual routines, that we have a tool that is just working with generic function handles. It has a standard metadata structure, and then it invokes the routines that we need for any particular data set. We also save intermediates so that we can quickly get a check to see that the processing worked, or we can identify if we had an issue. So this means that in order to accomplish all of this processing, we really just need to work with a spreadsheet that we list our data, we list where it's saved, we list which processing we need applied to the data, and then it can automatically figure out where we're starting and then flow through to completion. So from a user perspective, we really just have this simple spreadsheet, we have a go button, and then everything else is generated automatically. So we undertook an evaluation of performance with a heterogeneous data set. We had data acquired at 2 institutions. We had a mix of subject types. We had some healthy controls. We also had adult and pediatric patients. All the images were acquired in sagittal oblique view of the thoracic aorta. And we tallied our success rates by the individual subject types. So here's an example on the left of a subject that was successfully processed, or on the right, a couple of subjects that the data was not successfully processed. We also then compared, in a subset of the subjects, the adult subjects, the results of doing quantification with a fully manual processing versus our automated technique. And then we compared 3 different parameters in each of the subjects from the group. Here's a tally of all of our subjects. First, we can look at the totals. We have 387 subjects. Our largest groups were the adult controls and adult BAV. We have more of a variety of pediatric subjects. We had overall a quite high rate of successful processing, and so complementary to that, a low rate of failures. Looking at the adult subjects, we had actually a very high successful processing rate, but it was more mixed in the pediatric subjects, and so this is further work that we have to do. Then in terms of comparing the results of doing manual versus automated processing, we were focused on global aortic pulse wave velocity, the regional peak velocities, and then also the regional mean wall shear stress. We had a high degree of concordance between the results from manual versus automated processing, with close limits of agreement and a high degree of correlation. A similar story for the regional peak velocities, and again for the wall shear stress with close limits of agreement and high correlation between the two, between the results of the two methods. So what we've done here is we've converted a formulaic procedure into an abstracted processing framework, and then we've gone in and looked at each of the places where we had a human intervention, and we've substituted an AI processing step. But we've retained human readable intermediates so that we can at the end quickly verify that we've had either successful processing or identify data sets that have an issue. And the result is that we had a high rate of successful fully automated processing for quantitative 4D flow MRI. Thank you.
Thank you very much. We'll open this for questions.
Very nice data. Can you give us an idea of, is the automated processing truly real time? And if you don't do that, what is the time and experience center like yours spends doing all of this manually?
So for someone who's done a few data sets, I'll start with the manual part. 20 minutes per data set would be a pretty good amount of time. You have to sit there, you load the data, you have to pick your settings and so on. The first time that I ever did one, it probably was about an hour. We don't run the processing real time right now. It isn't really optimized for speed. What we've done is set it up so that it can kind of be run in a batch. You do it overnight, you get 300 subjects overnight. But you know, if that's something that's of interest, if you want to say get the results at the scanner, that is something that could feasibly be done.
Yeah, great work. Question about contrast or non-contrast, representativeness of the vendors, sequence types that might be represented in your data.
Yeah, we had a mix of contrast or non-contrast. All the controls were non-contrast. I think most of the patients were contrast. It was all acquired on Siemens systems, so we have not evaluated on other vendors yet.
Nice work. I was wondering how robust is your framework to domain shift, and how you handle that if there is some robustness issue with that. Thank you.
I'm sorry, I'm not actually familiar with the concept domain shift.
So it means that like you have different like scanner or resolution, spatial resolution, different artifacts and stuff.
Yeah, we do have a spread of resolution and scan parameters. So the voxel sizes were a bit varied, but in terms of evaluating on different scanners, we just haven't undertaken that yet.
All right, thank you very much. We'll move on to the next talk by Adash Aratikatla, which is direct quantification of mitral regurgitation volume and momentum using 4D flow MRI, spatial variability, and relationship with MR severity.
Great. Hello, everyone. My name is Adash Aratikatla, and thank you all for coming to this talk. Our presentation will be on the direct quantification of mitral valve regurgitation and momentum using 40 flow MRI, and we will focus on the spatial variability of this imaging modality and its relationship to MR severity assessment. So, mitral valve regurgitation is the most common cardiac valvular pathology, characterized by the inadequate closure of the mitral valve during systole, resulting in a backwards flow of blood into the left atrium. Clinicians look to quantify disease severity to further guide any potential interventional decisions. Imaging, mainly transthoracic echocardiography and 2D CMR, helps inform this decision. TTE is the mainstay imaging for MR, but is limited as it contains high inter-rater variability and 2D one-component velocity imaging constraints. 2D CMR is a supplementary method that we use that works by subtracting the aortic forward flow volume from the left ventricular stroke volume, resulting in the regurgitant volume. However, this subtraction of two large numbers can lead to the amplification of inherent measurement errors, and multiple valvular lesions or intracardiac shunts can yield inaccurate results. 40 flow MRI addresses many of these limitations by providing three-dimensional, three-component velocity vectors of MR flow. It allows us to retrospectively place a plane directly at the jet, allowing for more accurate quantification of regurgitant volume. However, it can be influenced by the flow entrainment effect, which is when surrounding fluid is drawn into the jet, which causes the jet flow rate to increase along the jet stream. Regurgitant volume is also limited, unfortunately, as it is sensitive to plane location, and previous studies have not investigated the sensitivity. And as 40 flow allows us to quantify additional dynamic flow parameters, we investigated the characteristics of the jet's momentum, a parameter that should represent the strength of the jet and in theory remains conserved along the entirety of the jet, independent of plane location. The purposes of our study are to investigate the impact of plane location on regurgitant volume and regurgitant momentum, and these metrics' relationship with clinically diagnosed MR severity. The table describes our study cohort and our patient severity gradings, with 36% of them being diagnosed with trivial to mild MR graded as 1, 49% with moderate graded as 2, and 15% with moderate to severe or worse graded as 3+. Here we've included a few points on the type of 40 flow MRI that we used in our study, along with the sequence parameters used. And now I just want to move on to how we quantify these flow parameters. So first, we detected a jet in the left atrium, determined its start and end time points, and then identified the location of the peak velocity voxel, which was located inside of the jet for the duration of the entire regurgitation. Then we placed an orthogonal plane at the peak velocity voxel location, which we termed the origin plane at x equals 0, where x represents the jet axis parallel to the jet flow direction. The 3D velocity vectors were all median filtered at all plane locations to enhance orthogonality between the plane and the jet. Next, we placed 3 planes, both upstream and downstream of the origin plane along the jet axis, with a distance of 2.5 millimeters between consecutive planes, creating 7 total planes with x coordinates ranging from negative to positive 7 and 7.5, reorienting them if necessary to ensure perpendicularity with the jet direction. Then we computed the through-plane velocity vectors at each plane location and manually contoured the jet regions based on the resultant images at all the time points. And we did this so that we could quantify the regurgitant jet's flow rate, volume, and total axial momentum. And then finally, we integrated the flow rate and momentum over time to get the jet's regurgitant volume and the jet's regurgitant momentum. So these first figures, they represent the regurgitant volume and momentum based on plane location. The x-axis notes the plane location from negative 7.5, which is a plane located most upstream of the jet, through the peak velocity voxel location or the origin plane at x equals 0, to positive 7.5 millimeters, the most downstream plane. We can see that the regurgitant volume consistently increases along the entirety of the jet, especially in MR severity groups 2 and 3, which again is most likely due to the flow entrainment effect. We can also see that severe MR patients demonstrated a higher rate of increase in regurgitant volume compared to the lower severity grades. The second figure, representing regurgitant momentum, can be divided into 2 distinct zones with different variability characteristics. So measurements upstream of the peak velocity plane show a marked increase in slope similar to the regurgitant volume, while those downstream remain relatively constant. Ideally, the upstream momentum would resemble the more stable downstream momentum, the more downstream region, and conform to the conservation of momentum principle, but we believe that this trend is due to the decrease in jet cross-sectional area as the plane moves closer to the valve, which in turn causes a large velocity gradient within a single voxel, leading to partial volume averaging and subsequent underestimation and signal dephasing errors. So the top box plot shows the significance shows that significance was achieved between MR severity groups 1 and 2, 2 and 3 plus, and 1 and 3 plus at all plane locations for regurgitant volume. Building onto what we talked about in the previous slide, the absolute regurgitant volume values increased as the plane was moved downstream. And now moving on to the bottom figure, the downstream regurgitant momentum measurements are more stable compared to the regurgitant volume values of the same region. These figures represent the reclassification of MR severity gratings for both of our flow metrics. After noticing that the regurgitant volume was more sensitive to plane location compared to the momentum, we evaluated how the sensitivity translates into patient severity classification. And so we used an ROC curve analysis to determine the thresholds for regurgitant volume and momentum for all three of our severity gratings. And when comparing the plane placed most downstream of the jet to the midplane, we saw that the number of patients with severe MR increased by 3 when we used volume as our classifier, but when we used momentum as our classifier, none of our patients had to be reclassified, again further demonstrating the relative stability of our parameter. The limitations of our study are that we had a small patient cohort, specifically in our severe MR group with only 8 patients, and a lack of reference data for regurgitant volume and momentum derived from 4D flow. And finally, the main points that we really want to emphasize are that both regurgitant volume and momentum derived from 4D flow demonstrate a significant association with clinically assessed MR severity. The direct regurgitant volume quantification is sensitive to plane location, possibly due to the flow entrainment effect. But in contrast, we see that momentum showed lower sensitivity to plane location variations, demonstrating its robustness in quantifying severity. MR is best quantified at the peak velocity voxel location. And finally, the clinical impact of regurgitant momentum is still unclear. However, the stability of this parameter should continue to be researched. And thank you all for your time, and I'll take any questions.
I just wondered whether you, since you have a 4D flow volume, why you didn't also look at aortic flow versus your LV stroke volume, just a very simple method, and how that correlated?
Yeah, so we essentially compared three imaging modalities. We used the TTE, the indirect method, which is what you just said, like the subtracting the aortic forward flow from the left ventricular stroke volume. But we wanted to look at 4D flow because that indirect method using 2D CMR tends to be limited if there's any valvular lesions or intracardiac shunts. So we wanted to try and look at a new imaging parameter for that.
But did the indirect method tally with that method or not?
I actually have a slide for that in the supplemental materials. But I think we saw that there was an overestimation in some of our patients for the regurgitant volume. I'm more than happy to show you our data after this, but yeah, thank you.
All right, let's thank our speaker again. Thank you. The next talk will be from Ning Jin on compressed sensing, accelerated ECG-gated, contrast-enhanced MR angiography on a 0.55 Tesla MRI system.
Thanks, Anthony, for the introduction. Today I'm going to share our initial experience of compressed sensing accelerated ECG-gated contrast-enhanced MR angiography on the 0.55T MRI system. For disclosure, I'm a full-time employee of Siemens Healthcare. So recent development of low-field ultra-wideband MRI system have opened up opportunities to address several challenges limiting the widespread application of a cardiac MR. Compared to 1.5T or 3T systems, low-field reduce the system cost and siting requirements and make the cardiac MR more available to previously underserved area. Wideband systems improve patient comfort, so we can scan patients who are severely obese or claustrophobic. Low susceptibility reduces the metal artifacts, and also low SARS enables interventional studies using the metallic devices and also improve the patient safety for patients with the metallic implants or ICDs. However, we all know the SNR is linearly related with the field strength, and for the low field, unavoidably, the SNR will be reduced. So recently, we have been developing a comprehensive cardiac MR protocols on the clinical low field system using research prototype sequences to address the limitation of SNR. And we demonstrated that with compressed sensing and some protocol optimization, we can achieve the adequate image quality for cardiac applications. So here are some examples for cine flow, first pass perfusion, LGE, and mapping. So 3D T1 weighted contrast enhanced MR angiography is commonly used for assessment of a thoracic aorta due to its fast imaging speed and also the high resolution and full coverage. However, its feasibility has not been fully tested on low field scanners. And in the recent studies, it found that ECG gating is very important in contrast enhanced MR angiography because it can significantly reduce the image blurring at the level of aortic valve and ascending aorta. In this study, it found that if we want to do longitudinal studies of ascending aorta, ECG gating is very important. However, for ECG-gated contrast-enhanced MRI on 0.55T, there are several limitations and challenges. First, the conventional sequence with parallel imaging acceleration is too slow to achieve the sufficient spatial resolution and coverage within the brown brush hole duration. Second, reduced SNR from low field make it challenge. And third, limited gradient performance on the systems further increase the temporal footprint. So we need to come up with methods to improve SNR and also reduce the total acquisition time. The purpose of this study was to evaluate the feasibility of a CS accelerated ECG-gated contrast-enhanced MR on the wideband clinical 0.55 MR scanner. So let's look at the method we use. First, we do the contrast injection. We use a Gatovis at the rate of 2 milliliter per second, either single or double dose, followed by a 25 milliliter saline flush. Then we perform Kerr bolus scans with a frame rate of 1 second, and as soon as we see the contrast arrive at the left ventricle, we start a gated MRI acquisition. Acquisition is acquired with a breath hold and gated to ECG. Images acquired in the diastole phase with segmented case-based acquisition. This prototype sequence provides a flexibility to determine when the center of a case space is acquired in which heartbeat. So in our case, we use a centric acquisition, and the center of case space is acquired early in the each heartbeat to reduce the cardiac motion artifacts. The sampling pattern is a variable density Poisson disk. Then we perform the gated MRI acquisition in the sagittal oblique orientation with a 3D gradient echo sequence. For reconstruction, we use a spatial L1 regularization with wavelet transformation. So we enroll 11 healthy volunteers for this study, 4 males, and the mean age is 41 plus minus 20 years. Images are acquired on the 0.55T clinical system. It's a Magneton Freemax by Siemens Healthcare. So the system is a 80 centimeter wideband system, and compared to the standard field scanners, the system has a reduced gradient performance. The maximum gradient amplitude is 26 millitesla per meter, and the maximum slew rate is 45 Tesla per meter per second. Here are the imaging protocols for gated MRA. Compared to the standard field, our TETI is slightly lengthened due to the reduced gradient performance. We use the acceleration rate of 7. The temporal footprint is about 300 milliseconds. The total acquisition time is from 12 to 18 heartbeats, depending on the spatial resolution. For image analysis, 2 independent readers measure the vessel diameters at 4 different locations. Sinus of Valsalva, ascending aorta at the level of the main pulmonary artery, arch between the left common carotid and left subclavian arteries, and the descending aorta at the level of the aortic root. So let's look at some results. Here are the representative results from 2 healthy volunteers. Here are the source images, and then we reformatted the source images into different orientations. 3-chamber, LVOT, SOV, ascending aorta arch, and descending aorta. We can see the aortic valve is clearly depicted in the 3-chamber and LVOT, and also the vessel at different locations is not blurred. So here are the comparison results of a vessel size measurement at the 4 different locations from 2 experienced reviewers. And the ICC scores demonstrate that agreement between the 2 reviewers are good and demonstrate a very good agreement between the reviewers. So in conclusion, we demonstrate the feasibility of a CS accelerated ECG gated contrast enhanced MRA on low field 0.55T WIBO clinical system with sufficient image quality for vessel diameter measurements. WIBO systems support imaging larger body habitats and can potentially offer benefits to patients experiencing claustrophobic. For our next steps, we will test this technique on patients diagnosed with aortic disease, patients with obesity, and patients experiencing claustrophobic. I would like to thank all my co-authors and thank you for your attention.
I'll start with a question. So you looked at the variability of vessel sizes between readers. Do you have a sense of how that compares to the variability at other field strengths?
We did not study this in our present work. I think in the future we can do that and see how that varies between different field strengths.
Great work, Ning. Nice images. Question about trying to enhance like the edge sharpness. Any consideration for maybe some AI super resolution with your reconstruction that might help the edge definition? Looked a little blurry on some of the images shared.
Yes, I would say indeed it's maybe a little blurrier compared to other field strengths because of the reduced SNR and also maybe the larger footprint of the acquisition in the heartbeat. So that's a very good direction to do. There are many works trying to enhance the edge sharpness using AI. We will look into that.
All right, let's thank our speaker.
Thank you.
We'll now welcome Dr. Jiayang Fan to speak about MR multitasking-based multidimensional assessment of the cardiovascular system, initial clinical experience.
Thank you, Anthony, for introduction. Good morning, everyone. As you all know, MR imaging modality is very useful for evaluating cardiac and aorta disease. And these applications really can benefit from some key capability of MR. For example, we can provide red blood or dark blood image contrast, and we can resolve the cardiac motion and the respiratory motion, and we can separate the water and fat for some disease assessment. However, all these clinical needs will make the clinical flow workflow very complex and time-consuming. And for example, typically we need separate scans with several non-standard planes, and also we need ECG triggering with multiple breath holds. So our goal is to make the protocol much simpler and we can provide comprehensive information. So that's why we designed this multitasking-based MAX sequence. And this sequence actually, we utilize the T2IR prep to introduce T2 immersion recovery signal evolution. And as you can see, based on the simulation, you can see we continuously sample this signal evolution curve, and we can generate continuous image contrast. Especially, we can generate bright blood, dark blood, and gray blood. And we use the tiny golden angle step stars acquisition to make the scan robust to cardiac motion. And we utilize the MR multitasking to formulate these images as a 7-dimensional problem. So we have a 3-dimension for space information, and also we resolve the cardiac motion and the respiratory motion, and obviously T2IR signal evolution, and also the 2 echo time. We utilize the Dixon method to acquire 2 echoes and for water-fat separation. So the finalized version really allow for the cardio-aortic imaging without the ECG triggering navigator gating. And we acquired the large spatial volume to cover the whole cardio-aortic system with a high spatial resolution, 1.4 isotropic millimeter isotropic resolution. And the total scan time will be 10.5 minutes. And this is an example on the healthy volunteer. As you can see, we can really provide a different contrast weighting, and this is 3D coverage. You can really flexibly reformat image for any angle for better realization. And also we have dynamic information, which is cardiac phase resolve. And also we can separate water and fat for example, fat quantification. And in this particular project, we want to further perform a clinical feasibility study in a small patient cohort. And we want to specifically evaluate the image quality and especially the diagnostic accuracy compared to the clinical final diagnosis, and quantitative measurement compared to standard CMR exams. So we recruit 2 healthy volunteers and 24 patients with suspected cardiovascular disease. And the scan was done on Siemens 3T. And we collect the information from the clinical imaging and also standard CMR. And the image quality, we use the 0 to 3 4-point scale, and we also evaluate inter-reader agreement. And for diagnosis, we compare the diagnosis from MT Max to the final diagnosis based on the clinical imaging, including echo, CMR, and other clinical information. And for quantitative analysis, we measure the following parameters. And this example for measuring the ejection fraction, and also for the cardiac chamber, myocardium thickness or vessel wall thickness, we actually utilize our dynamic contrast weighting. We can identify the best contrast frame to measure this. And this is the result. So among the 26 human subjects, we have 22 subjects received at least good or excellent image quality. And we observed a great inter-reader agreement. And for diagnostic accuracy for these 4 different categories of disease, we also observed good to excellent agreement between MT Max and clinical standard imaging and clinical information diagnosis. And in terms of quantitative analysis, we have 16 subjects with standard CMR, and we observed moderate to excellent reliability in all these quantitative markers. So I would like to conclude my talk with several clinical examples. So this example shows left atrial appendage thrombus. And as you can see, on the different contrast weighting, we really can depict the lesion with different signal characteristics. So from these dark blood images, we can really tell this is a kind of a subacute thrombus, which has a much lower T1 value. That's why you see the hyperintense signal. And this is the left ventricle thrombus. Again, here, we can see clearly from different contrast weighting. And this is a left ventricle thickening. And from the dark blood contrast weighting, it's really easy to measure the thickness. And this is left ventricular enlargement. And the aortic vasculitis, we can really see there's diffuse vessel wall thickening and also edema signals. And from the MRA, you can really measure the vessel diameter. So in this product, we demonstrated the clinical feasibility of using MT-Max for cardiac and aorta assessment. And we observed a high diagnostic accuracy and comparable quantitative measurements. And in conclusion, we believe this technique can serve as a gatekeeper because a gatekeeper for the cardiovascular disease because of large spectral coverage, high resolution, short scan time, and easy setup, and it's non-invasive and no radiation. We would like to thank the funding supporter, and thank you for your attention.
So I'll actually ask a question, which is you do a comparison, right, against the standard clinical measurements, but you have to choose a contrast to do a comparison, such as like wall thickening. You showed that it's very convenient to do that on a black blood image, but the standard images, were they dark blood, gray blood, black blood, and how does that potentially influence agreement between the two methods?
For some quantification, we cannot really match our protocol with conventional protocol, but we just want to follow the standard clinical standard, right? So if standard requires black blood to measure, we just follow that. But for our protocol, we want to make use of our really unique information, whichever contrast weighting best for our purpose, we will choose it. So there's some discrepancy.
This is really great work. Quick question.
Thank you.
A lot of our patients have arrhythmias. Do you have any experience with the impact of arrhythmias on the results here?
Yeah, this is a good question, very good question. So to be honest, we don't have a lot of experience with arrhythmia patient cohort. This is actually our next step to evaluate.
All right, let's thank our speaker.
Thank you.
We'll now welcome Yiming Tao to discuss recurrent neural network-based simultaneous cardiac T1, T2, and T1 row mapping using Cartesian sampling.
Thank you for your introduction. But for some reasons, the speaker Yiming Tao isn't here. I'm Yuan Ren, her colleague in Shanghai Tech University. I will be presenting this work on her behalf. The topic is recurrent neural network-based simultaneous cardiac T1, T2, and T1 row mapping using Cartesian sampling. I have nothing to disclose. Quantitative myocardial tissue relaxation measurements technology has emerged as a non-invasive and powerful tool in diagnosing cardiovascular diseases by precisely quantifying myocardial tissue characteristics. The primary quantitative parameters used for myocardial assessment include T1, T2, and T1 row. Furthermore, combining T1, T2, and T1 row maps can provide additional valuable information for clinical diagnosis in a single scan. Recent research has proposed a free-breathing multi-parametric mapping techniques that incorporates a navigator for through-prime motion correction and achieves B1 non-uniformity correction using a single condition acquisition and dictionary matching. It enables the simultaneous quantification of myocardial T1, T2, and T1 row in a single breath hold MR scan. Oh, sorry, in a free breathing scan. However, the dictionary generation and the pattern matching steps are time-consuming, especially for comprehensive simulations to generate the database. Moreover, to reduce the reconstruction time for multiple parametric mappings, the size of the dictionary needs to be limited. This limitation can introduce discretization errors, resulting in incorrect parameter estimation. To address these challenges, several studies have proposed combining neural networks with MRF technology, offering improved accuracy and computational efficiency. Previous works have demonstrated the reliability of using recurrent neural networks to accelerate the reconstruction process of quantitative parameter mapping, particularly for time-dependent sequences like cardiac MRI excitation. In this study, we leverage RNN to expedite the reconstruction of cardiac quantitative parameters, enabling the generation of simultaneous T1, T2, and T1 row parameter maps within 2 seconds after a single free breathing scan, compared to the original dictionary matching method at rate 60 times. As for the data preparation step, we can obtain a comprehensive evolution of signal intensity for each pixel using the block equation. As illustrated in this figure, the 16 data pairs consist of time points scanned at the center of K-space and the corresponding signal intensities collected from each image form a unique time series determined by a set of T1, T2, T1 row, and B1. Phantom experiments were conducted on 3 different days to evaluate the accuracy of the 2 techniques in multi-parameter estimation. The first row on the left represents the quantitative maps of 10 tubes obtained from 2 techniques, respectively. Additionally, the following graph illustrates the estimation results at different heart rates, demonstrating the stability of our method. And the right column shows the correlation analysis to assess the relationship between the average T1, T2, and T1 row values with the reference measurements. Both methods exhibited excellent coefficients of determination in all cases. These results indicate a high accuracy between the estimated values and the reference measurements for all 3 parameters. In vivo studies for each subject, MR images were acquired of the midlife ventricular short axis at the basal, middle, and apical levels using the previously mentioned free breathing multi-parametric mapping sequence. As a comparison, we also conducted additional sequences for T1, T2, and T1 row mapping as the conventional method. This figure shows representative T1, T2, and T1 row maps for a healthy subject, comparing the results obtained using the RNN accelerated method, the dictionary matching method, and the conventional method. Additionally, the left figure shows both eyes representations of mean values and their respective standard deviations for the T1, T2, and T1 row maps in the 3 corresponding methods. Both methods show higher T1 mean values and larger standard deviations, whereas yielded lower mean T2 and T1 row values compared to the conventional method. However, the final result of 10 healthy subjects in the right table demonstrates the high consistency of the myocardial quantitative parameters obtained using the RNN accelerated method and the dictionary matching method. In conclusion, our proposed network provides an efficient and accurate solution for estimating free breathing multi-parametric maps in real time, offering comparable performance to the dictionary matching approach while requiring less storage and faster speed. That's all. Thank you for your attention.
Yes, it's a nice work, And have you tried with MR fingerprinting with your technique, or do you have some idea about the efficiency between your methods and MR fingerprinting?
That's a good question, but I'm not in the study of mapping, but I think it's maybe in the future work. Thank you.
So I may have missed it, but how much faster did you say the AI inference was compared to the dictionary generation and matching?
Our method needs only 2 seconds to produce a mapping. But the time of rejection is not calculated in.
Okay, thank you. All right, let's thank our speaker once more. We will now welcome Augustine Augier, who will speak on free-running, self-gated, motion-resolved 5D whole heart anatomical MRI at 3 Tesla without contrast agent.
Hi, good morning everyone. So, cardiac anatomy and function are routinely assessed using 2D cine MRI, implying planification to reach like the 2D slice of interest, and this procedure has several drawbacks, as like the need of patient cooperation for the bracehold, present some operator dependency, take some time for every 2D slice of acquisition for the planification and acquisition, and also need some external cardiac triggering device. To overcome this issue, free-running acquisition have recently been developed. So the idea here is to have only one 3D acquisition instead of all the 2D acquisition, and this 3D acquisition is then retrospectively motion resolved. Such acquisitions are based on continuous acquisition using, for example, a phyllotaxis trajectory, where the first readout of the radial arrangement is a superior inferior readout that is used to retrieve the cardiac and respiratory signal, and this physiological motion are used to bin our data and then reconstruct our 5D images using compressed sensing. So we have 2D cine like we integrate for cardiac anatomy and function, and free-running acquisition simplifies the workflow with more comprehensive coverage and a shorter scan time. However, free-running acquisition has been initially designed at 1.5 Tesla using BCFP. At 3 Tesla, GRE will be preferred to its reduced susceptibility to field homogeneity, but GRE offers a poor blood to myocardium contrast. So far, free-running acquisition at 3 Tesla have been conducted with contrast injection. So in this study, we propose a free-running framework for conducting non-contrast 5D MRI of the whole heart at 3 Tesla, and this in 5 minutes. So first, to generate contrast, we interrupted our sequence with T2 preparation pulses and recovery time modules. And furthermore, we use a water excitation RF pulses, which has been essentially designed to suppress fat, but that we use here to reduce tricking artifact to improve the overall quality of our image. So now that we are like acquisition scheme, we have to choose our like sequence parameter, and how do we get the parameter who gave us the optimal blood to myocardium contrast. For that, we leverage APG simulation to run thousands of simulation with all the possible combination of sequence parameter, and we kept the parameter who gave us the best theoretical contrast between the blood and the myocardium. So now we have to face the issue of motion extraction. We kept the first readout as a SI readout, but now we have like this, the signal of this SI are perturbated by the T2 preparation pulses, and we also have like a lower temporal sampling of this SI due to the interrupted nature of our sequence. For respiratory, it's still possible to extract from the SI matrix, as respiratory is a large component with a low frequency pattern, but is not that straightforward for cardiac signal. So in this study, we use a fingertip pulse oximeter. So once we get this motion, we use them to bin our data, and at this step, we use the recent work of my colleague in Lausanne to compute the deformation field between the build. And this motion field are then integrated in the compressed sensing based reconstruction to compensate for interbeam motion. And we finally get our 3D images for each cardiac and respiratory phase. So one of the main advantage of this method, like every free running acquisition, is that we can retrospectively recreate every 2D slice known by the clinician. And in this study, we especially recreated the short axis and 4-chamber view to be able to compute the end diastolic, end systolic, and volume, as well as the ejection fraction, to compare this metric with those extracted from the classical 2D cine to validate our method with statistical analysis. So we perform our validation on 11 volunteers at 3 Tesla, and here you can see the sequence parameter determined by EPG for a 5-minute acquisition of a 2mm voxel size image. So here, first overview of our results. Several things to notice on this slide. So on top, we have the 2D cine slices, and at the bottom, the reformatted images. First, the 2D cine are acquired during a breathhold, and the reformatted images here correspond to the end expiration phases. So it's normal to have like a slight offset in the spatial location. We also notice that we have less contrast in our images, but we are still able to differentiate the blood pool and the myocardium, which is of utmost important. And this is just like qualitative results. So to move to quantitative metrics, we segmented the left ventricle on both our images, and we see here that we have a very great agreement for these metrics. We have a slight underestimation of the end diastolic and end systolic volume, but it seems quite consistent because we have like a bias of ejection fraction of less than 2%. Regarding the reproducibility, we see that we have a very nice reproducibility too, because we have regarding like the ICC and the standard error measurement. So to conclude, in 5 minutes of acquisition, we are able to obtain an atomical 5D image of the whole heart at 3 Tesla without contrast agent, and we validated our method with a height agreement with reference clinical acquisition. We still have some limitation. First, on the validation, we need to extend it to a patient, and also we need to perform a double-blind segmentation and analysis, as so far only one expert has been involved in this process. We also still need external cardiac triggering device, but on this aspect, we are currently working, investigate singular spectrum analysis method to directly extract the cardiac signal from the SI matrix. On further perspective, we can extend this framework to acquire a higher image resolution to enable the visualization of small cardiac structure. And for example, we give it a try with 30 minutes of acquisition that will give us the opportunity to have a contrast-free 5D coronary imaging at 3 Tesla. But this still have to be investigated. And on that, I would like to thank my team in Lausanne for their work and support, and you for your attention.
Thank you very much. So you mentioned the dependence on pulse oximeter as a limitation, which, as I understand, is because you introduced the T2IR pulse. So how much contrast to noise ratio improvement did you get by introducing the T2IR?
I didn't like compute this matrix yet, but without like the T2 pulses, for sure we'll have like we'll not have enough contrast to segment the left ventricle. The idea here is just to have enough contrast to segment and to reproduce the function of the heart for diagnosis or things like that.
Nice work. Maybe 2 questions. Length of the reconstruction. Importantly, we want to be able to see that there's going to be useful images, coming from the acquisition before they take the patient off, and then the way that we would then take the data we get and translate it into patients. Arrhythmias, a common problem. Any idea how this might work in patients who have arrhythmias?
Normally with arrhythmia, if we can still detect the I mean like the cardiac signal from the oximeter were normally supposed to still able to reconstruct our image, but it's true like with free on acquisition always like face the issue of arrhythmia. I never like try, so I cannot like give like an answer, but in theory it could work if the key is to get the proper cardiac signal, and oximeter actually will be better than extracted from the SI matrix in my opinion, because it's not that straightforward at all.
So I was curious, how do you maintain the effect of the T2IR pulse? Were you splitting up the cine acquisition into batches, or because I assume the T2IR pulse will only last for a relatively short time, and will change, the contrast will vary over the cardiac cycle?
Yeah, but like this was the point of like this PG simulation, was to determine like how often we have to play these T2 preparation pulses to keep a nice contrast between the blood pool and the myocardium. And so instead of doing all this empirical study, we just leverage a PG simulation to give us like the optimal sequence parameter for a fixed timing to still be able to have a nice contrast between the blood and the myocardium.
All right, thank you very much. All right, we will now welcome Zhongqin Zhao, who will give a talk on self-navigated coronary MR angiography for coronary artery aneurysm detection in Kawasaki disease at 3 Tesla.
Thank you. Good morning, I'm Zhongqin Zhao from West China Second University Hospital. My presentation is self-navigated MRA for aneurysm, coronary aneurysm detection in Kawasaki disease at 3T, comparison with conventional diaphragm-navigated MRA. Evaluating the size of coronary aneurysm is necessary for risk stratification and long-term prognosis of Kawasaki disease. Diaphragm-navigated MRA has been used in patients with KD with images equivalent to DSA. However, application remains limited due to long and unpredictable acquisition time. Self-navigated MRA directly detects the movement of the cardiac blood pool without using diaphragmatic navigator, may be superior in solving irregular breathing and poor coordination in children to shorten scan time. So this study aims to assess the application value of self-navigated MRA for coronary aneurysm detection in children with KD and compared with diaphragmatic navigated MRA. Finally, 74 children diagnosed with KD in our hospital were enrolled. All the patients underwent the 2 MRA sequence in a randomized fashion on the same day. 16 of them underwent coronary CT angiography, and 16 of them underwent DSA within 1 month. This is image parameters of the 2 sequence. Images acquisition was completed on a 3T clinical MRI scanner. We analyzed the quantitative and quantitative parameters of images acquired through the 2 sequences to compare the image quality. The overall image quality was using a 3-point grading scale. A scale higher than 1 was considered to be a good diagnostic quality. The 3 coronary arteries were divided into 9 segments. Image quality of segments was graded on a 5-point scale. Any segment with a grade higher than 0 was considered to be visualized. Inhomogeneity of the blood pool signal, contrast ratio of blood and myocardium, and vessel length of the 3 coronary arteries were measured for quantitative image evaluation. For quantitative analysis, 93% of overall image in self-navigated reached good diagnostic quality, while 98% of overall image of diaphragmatic reached good diagnostic quality. There was no difference in ratio of overall and segmental image quality to reach the clinical diagnostic criteria between the two sequences. For quantitative analysis, the scan time was shorter using self-navigated CMRA. Self-navigated had a significantly more homogeneous signal in the blood pool. No difference was found in vessel length of 3 coronary arteries in two sequences. The contrast ratio of blood and myocardium in self-navigated CMRA were not different from that of the other one. For diagnostic performance for detection of coronary aneurysm, there was no difference in the diagnostic accuracy of self-navigated and diaphragmatic for CAA detection on per patient, per vessel, or per segment basis. 4. The newly proposed self-navigated CMRA had a reliable diagnostic performance and clinical application value for CAA detection in children with KD and at 3T, and compared with diaphragmatic self-navigated CMRA simplified the scanning procedure and shortened the scan time with comparable image quality and diagnostic accuracy. And then I want to introduce my organization here. Our hospital, West China Second University Hospital, is Chinese Children's Regional Medical Center and the largest women's and children's hospital in Southwest China, with over 3.5 million outpatients and 900 inpatients per year. And our department of pediatric cardiology is ranked top 3 in China, with over than 1,000 children per year inpatient with Kawasaki disease. And our department of radiology is with over 1,000 pediatric CMR per year. And our group initiated the first pediatric cardiovascular disease database in China with over 200,000 data. Focusing on early evaluation and risk stratification of cardiovascular disease in children, and like type 1 diabetes, myocarditis, and Kawasaki disease, and so on. And we have the largest published cohort of Kawasaki disease underwent CMR. Our future vision on Kawasaki disease is undergoing multi-center cohort in China and looking for opportunities international cooperation to expand the application of cardiovascular image on myocardial injury risk stratification and prognosis in KD. So if you are interested in our study, please contact us. Thank you.
So I noticed that your self-navigated sequence actually had a higher success rate than the diaphragm navigator. Was that purely because of the shorter scan time, or was the diaphragmatic navigator always scanned afterwards, in which case the child may have started to get a little antsy?
It's performed in a randomized fashion, yeah. Sorry.
No, that answers it. Thank you. Yes. Yeah.
Thank you.
All right. I think in the interest of time, we'll move on to the next talk, which will also be given by the same speaker. And this talk is comparison between diaphragmatic navigated and self-navigated CMRA at 3T in pediatric patients with congenital coronary artery anomalies.
Hello. The first author of this abstract is Shigamo, but she cannot come here, so I instead of her for presentation. The topic is comparison between diaphragmatic navigated and self-navigated coronary magnetic resonance angiography as treated in pediatric patients with congenital coronary artery anomalies. Coronary artery anomalies encompass several congenital conditions, including the abnormal arrangement of the main coronary artery and anomalous course, with prevalence ranging from 0.2 to 5.8%. CEA contributes to myocardial ischemia and sudden cardiac death. Thus, the accurate diagnosis of CEA is essential for this stratification and therapeutic approach. Echocardiography, ICA, and CCTA have some limitations in detecting CEA, such as poor acoustic window, invasive and high radiation dose. CMRA is increasingly used in diagnostic CEA. However, the most conventional approach, diaphragmatic navigated, is limited by long scan time, high risk of failure, and complex scan procedure. Self-navigated can achieve simplifying the acquisition, improving the scan success rate, and shorten the acquisition time. Several studies have reported that self-navigated CMRA at 1.5T was highly accurate for diagnosing CEA. However, data for CMRA at 3T remains rare, and the clinical application of 3T CMRA remains to be investigated in the clinical approach of pediatric patients with suspected CEA. Therefore, the study aims to determine the clinical application value of 3T self-navigated CMRA in pediatric patients with CEA and compare it to conventional diaphragmatic to compare the scan time, success rate, and image between the two sequences, and comparing the diagnostic value of these two sequences. We enrolled 65 pediatric patients with suspected CEAs in this study. In this study, both the diaphragmatic and self-navigated approaches were acquired in randomized order, with GRE sequence after 12 to 15 minutes, contrast injected without additional dedicated contrast agent administration, with 39 of them undergoing CCTA or ICA as well. We measured and compared the success rate, scan time, visual score of the 9 main coronary artery segments, vessel sharpness, and vessel length between the two sequences. The diagnostic accuracy was compared using CCTA or ICA as a reference. The scan success rate of self-navigated was higher than that of diaphragmatic. The scan time of self-navigated was shorter than that of diaphragmatic. The acquisition efficiency of diaphragmatic was about 40%. For self-navigated, 100% acquisition efficiency was achieved. There was no difference in vessel length of all coronary arteries, visual score, and vessel sharpness of the left circumflex coronary artery between the two sequences. The visual score and vessel sharpness of the right coronary artery and left anterior descending coronary artery were significantly improved using diaphragmatic compared with the other one. The sensitivity, specificity, positive and negative predictive value for the detection of CEA showed no difference between the two sequences. The figure shows the representative images of self-navigated, diaphragmatic, and ICA and CCTA in pediatric patients with CEA. With those results, we come to the conclusion that our findings demonstrated that both self-navigated and diaphragmatic in CMRA provide clinical application value in pediatric patients with CEA and have similar diagnostic performance. Although the image quality of self-navigated CMRA is slightly inferior compared to that of diaphragmatic, self-navigated CMRA allows for a more simple scanning procedure. Thanks for your listening.
Yeah, very nice talk. So with these coronary MRAs, the selection of the quiescent period, the resting period of the heart is very key. So what was the temporal footprint of your self-navigated, like the readout duration, and then also for the conventional like coronary MRA? And then did you make sure that you were choosing your trigger delay such that you're imaging at similar sort of a resting period of the cardiac cycle?
The trigger delay in the two sequence is the same. We use the same trigger delay time and the duration. Most is in systolic phase.
Okay, great.
Thank you.
So in the first talk you gave in Kawasaki disease, I don't think there was a difference in image quality between the two sequences, right? And then here there was a difference in the LAD and the right coronary. Do you have any sense why this patient population or this study showed a difference between the two as opposed to the other study?
The two study in the diaphragmatic, the image quality of the diaphragmatic in the second study is more is good is better than slightly better than the self-navigated, and the age of the two studies is different. The age of the second study is about 8 years, and the first is around 6. Thank you.
All right, thank you very much. We will move on to the power pitch portion of this session. And we will again be kicked off here by Dr. Zhou, who will stay on the stage. We're really testing her endurance here. The power pitch will be application of 3T non-contrast coronary MR angiography in children with Kawasaki disease.
Thanks. The presentation is application of 3T non-contrast coronary MR angiography in children with Kawasaki disease. This study aims to explore the diagnostic accuracy and application value of 3T non-contrast CMRI in evaluating coronary artery lesions in children with Kawasaki disease. Finally, 75 children diagnosed with KD in our hospital were enrolled. All the patients underwent CMRA and echocardiography in 1 week, 13 of whom underwent coronary CT angiography and 13 of whom underwent invasive coronary angiography within 2 weeks. The diagnostic performance of CMRA and echocardiography was evaluated with CCTA or ICA as reference standard by per patient, per vessel, and per segment basis. The distribution of coronary aneurysm and thrombosis were recorded and compared between 2 methods. This is the characteristics of patients with KD underwent CMRA and echocardiography. The overall image quality of CMRA, for 53 patients had image score of 3, 20 patients had a score of 2, and 2 patients had a score of 1. In total, about 97% of patients with image reached diagnostic quality. For comparison of the diagnostic value of CMRA, the echocardiography in detecting CAA, among the 26 patients underwent CCTA and ICA, CMRA showed a higher sensitivity than that of echocardiography, both in per vessel, proximal segments, and middle and distal segments. A total of 115 CAAs was found by CMRA, while only 87 CAAs were observed by echocardiography. Of the CAA missed by echocardiography, 16 were located in RCA and 17 were located in middle and distal segments. The figure is a representative image of CMRA. Aneurysm in distal segment of RCA was detected by CMRA but missed by echocardiography. The 3T non-contrast CMRA is non-invasive and non-radiation, and the image quality can meet the needs of diagnosis, especially for detecting OCAs in RCA and in middle and distal segments of coronary artery in KD patients. Thanks for your listening.
All right, let's thank Dr. Zhou for all three of her talks. And we will now welcome Yuka Otaki to speak about visual assessment of 4D flow cardiac MRI in patients with hypertrophic obstructive cardiomyopathy undergoing alcohol septal ablation.
Thank you. I have no disclosures. So 4D flow cardiac MR has been increasingly applied in cardiovascular field, providing information of fluid dynamics and non-invasively. So the purpose of our study was visually to assess vortex flow in left atrium, sinus of Valsalva, and ascending aorta using 4D flow cardiac MR in HOCM patients undergoing alcohol septal ablation. So total population is 26 patients, and this is our imaging protocol. And we visually identified vortex flow in sinus of Valsalva, left atrium, and ascending aorta. And we defined improvement vortex flow was decreased or minimized vortex flow. So here's the example of the healthy patient and HOCM patients. On the left side, you can see healthy patient image. There's no vortex flow in ascending aorta, sinus of Valsalva, and left atrium. On the other hand, on the right side, in HOCM patient image, you can see a significant vortex flow in ascending aorta, sinus Valsalva, and left atrium. So this is our patient characteristics. In most of cases, the alcohol septal ablation was successful with significant reduction of peak velocity at LVOT. And this is an example whose alcohol septal ablation was successful with significant reduction in LVOT velocity by echocardiogram. And on the left image, you can see significant vortex flow in ascending aorta, sinus of Valsalva, and left atrium. And on the right image, after procedure, those vortex flows are reduced or disappeared. This image is a case example with the patient whose alcohol septal ablation was not successful. The peak velocity increased after the procedure. On the left side, this image is before the procedure, and you can see vortex flow in ascending aorta, sinus of Valsalva, and left atrium. And after procedure, those vortex flows in ascending aorta and sinus of Valsalva remained, whereas left atrium vortex flow disappeared. This graph shows the frequency of the presence of vortex flow in sinus of Valsalva, ascending aorta, and left atrium. And compared to pre-procedure, after procedure, the frequency of the vortex flows in each region significantly reduced. This figure shows the frequency of the minimized vortex flow, comparing between the patient whose procedure was successful and not successful. Compared to patient with not successful group, the frequency of the minimized vortex flow was significantly higher. So in conclusion, visual assessment of 4D flow cardiac MR in patients with HOCM undergoing alcohol septal ablation may be useful for understanding hemodynamics of left atrium, ventricle, sinus of Valsalva, and ascending aorta. Yeah, we are trying to quantify the vertical flow, and also we are going to investigate a correlation with echocardiogram or catheter or patient outcome in the future. Thank you for your attention.